Now I call upon Dr. Medha Prabhudesai for her talk on critical elements of disc evaluation. Dr. Medha, please.
Good morning, everyone. At the outset, I would like to thank chairpersons and AIOC for giving me this opportunity. I'd be talking on critical elements of optic disc evaluation. You have to do a careful exam and keep an open mind while evaluating the optic nerve head. Clinical evaluation is the most overlooked skill because ONH signs have high sensitivity and specificity for diagnosis of glaucoma. We need a systematic approach which improves detection of glaucoma. Documentation can be done baseline with color and red-free photographs, and stereo photographs are preferable. Serial photographs are important because we can identify the progression at an early stage. There are various signs of glaucoma depending on these 5 categories. These are: determine the size and shape of the optic nerve head, evaluate NRR and its thinning, check for vascular signs, look for RNFL thinning, and examine the peripapillary atrophy. So before that, we should know how a normal ONH looks like. It follows the ISNT rule. A horizontal cup is much more than the vertical cup. There is variation in disc size in normal ONH also. So depending on that, the CD can change, and this affects the apparent neuroretinal rim. So what are the techniques? This is a gross technique with Welch-Allyn microscope. It gives in 5 degree aperture gives a 1.5 mm area and 1.77 millimeter square, and this is a slit lamp biomicroscopy scope where you can have a handheld lenses. A Vogue 90D will give, if you multiply by 1.33 exact area of the disc. So how to identify clinically? So if you have a fovea centralis and optic disc size, and if you see how many diameters are there, if it is more than 2 to 2.5, you can say that this is a small disc. This is a medium disc because it is almost 2, and this is a large disc where it is just 1.5 disc diameters. So high CD, always large cups. They have large cups, so you need to investigate and do not label them as glaucoma. Physiologic cupping, you need to document and see if they are progressing. Myopia, obviously, it is a diagnostic dilemma, and you need to document and investigate. Tilted disc in myopia, always investigate. Tilted disc syndrome is there, where there is a bilateral inferiorly tilted disc, which is seen here. So this is a different type, and this is not glaucoma. Now identify NRR and thinning. You need to identify the age of the disc, follow the course of the blood vessels, where they over the NRR, and identify the inner margin of the cup. Similarly, again, identify where the vessels traverse the optic nerve and identify the disc margin and NRR. Circumlinear vessels, usually they are on the inner margin of the NRR, and here it is easy to find out where the NRR ends. So disc asymmetry, unilateral in a large cup and large disc can be normal, but if the disc size is same and NRR is thin and large cup, should be investigated. Vertical enlargement of the cup in a vertical oval disc can be normal, but vertical cups and thin NRR along with RNFL defects can be glaucoma. So pallar cup discrepancy is a pathognomonic sign, and you need to identify these patients very carefully, especially if they have wedge-shaped RNFL defects where the notching is there. So cupping more than pallar, definitely glaucoma, but pallar more than cupping may not be glaucoma. Here you can see that it's a patient has a NRR pallar, and here we investigated, and the patient had something else which had with me underwent, he underwent MRI. Concentric atrophy and laminar dot sign can be seen because of loss of neuronal tissue. This is advanced cupping here. Check for vascular signs. This is a significant finding, that is a splinter or transhemorrhage. This can be first sign of glaucoma, and it is seen in NTG with large IOP fluctuations, and hence you need to monitor and need more aggressive therapy. Bayoneting is seen, there is sudden change in direction of when they come out of the NRR, and this is called as bayoneting. Bearing of circumlinear vessel is because of the loss of neuronal tissue here, and overpass cupping is also seen where the vessels suddenly dip into the nerve because of the loss of tissue. So check for vascular signs. NVD can be there, but this is disc hemorrhage. Bayoneting can be seen when the cups are deep, but this is glaucoma here. And circumlinear vessels, this can be normal, and bearing can be abnormal. So check for RNFL thinning. Here there are slit defects which can be normal, which may come and go, but these slit defects need definitely examine properly and document them. These are the wedge defects, superior and inferior pole, and diffused RNFL loss, so need to careful examine. So if you see the normal ONH and you cannot make out whether the NRR is there, so there can be a wedge shape defect which needs investigation. Peripapillary atrophy, alpha zone and beta zone is also important. Beta zone is seen in patients with POH and NTG and hence needs to be carefully understood. So this can be myopia, but the other two can be glaucoma. So advanced or this thing, is it normal? This is a peripapillary atrophy, but this is definitely a physiologic condition and you need to investigate, but not a glaucoma. Always watch for progression because the disc hemorrhages can disappear and reappear at different stage and they can precede the RNFL defects over there. Here also there is a progression of wedge step defect and an inferior thinning of RNFL slit defect. Some discs are definitely outliers and you cannot make out whether they have glaucoma or not, so you need to document them. So this is a patient, medium-sized disc, all the signs are there. Again, a left eye, all the signs are there. So these patients have glaucoma. Always, always document. Don't forget documentation of these patients. Always remember there can be comorbidities like PDR or ARMD because they are all elderly patients. Don't ignore large cups because they can be normal, can have advanced glaucoma, and can harbor something else that is a neurological condition. So always note the disc size. NRR is important and not the CD. Check for palmar cup discrepancy. Find and observe vascular signs. Evaluate RNFL defects. Note the signs of progression. Keep a high level of suspicion when the findings are atypical. Remember that a patient may have more than one disease, and keep in mind that everything that looks like glaucoma may not be glaucoma. Thank you for your.
Thank you, Dr. Medha. It's a very important method for examination in day-to-day practice. Very extensive talk. Thank you again. Now I